I welcome you all for today's webinar, Paradigm Shift in the Management of Lung Cancer. I would like to thank our convener, Dr. Chandra Gowda, and co-convener, Dr. Ramesh Shehrawat, for organizing this conference. With immense pleasure, I would like to invite our first speaker, Dr. Amit Badola, who is consultant medical oncology at Max Super Speciality, Dehradun, for the first talk on reinventing adjuvant therapy in EGFR mutation NSCLC.
I hope my slides are visible.
Yes, sir, they are visible.
Good evening, everyone. I'm Dr. Amit, consultant medical oncologist at Max Hospital, Dehradun. Thank you, AstraZeneca, for having me here. And my topic is reinventing adjuvant therapy in EGFR mutated early lung cancer. This topic is very interesting because it's reinventing. We have seen failure with the first generation EGFR TKI in this setting, and now we are having a better medication available for that. That's why this topic is reinventing adjuvant therapy. If we talk about the survival outcome in the resectable non-small cell lung cancer, we know that as the stage advances, the survival also decreases. For stage one, the 5-year overall survival is approximately 65 to 70%, while it goes down to 30 to 45% even in the resectable non-small cell lung cancer patients. That means we witness a very high recurrences, either local or distant. I think 3 or 4 years back, we didn't have any recommendation, any molecular testing available uh, in guidelines for early lung cancer. But now we have EGFR, PDL1, and ALK as well in the early stage as per ELINA trial. So we should do all these tests in early lung cancer to decide our therapy. So talking about the current testing and the treatment pattern in the early stage, we know that the incidences of EGFR mutated in early in the advanced stages. This paper was published and presented in ASCO 2023, where they have seen the prevalence of EGFR mutated uh, non-small cell lung cancer in stage 1 to 3. And surprisingly, the incidence was more. Every other patient was having these mutations. And this is true in our clinical practice as well. Whosoever is having surgery, they mostly are having EGFR mutation positive. So in this retrospective analysis as well, we have seen almost 49% patient were showing EGFR mutation. And the common one are exon 19 deletion and exon 21 L8R mutation. And if we talk about the treatment pattern, 73% patient only receive surgery, while 22% receive surgery and as well as systemic therapy. So there was a good chunk of the patient who didn't receive any adjuvant treatment in this retrospective trial. So we know that, as I saw, we discussed the survival in the early non-small cell lung cancer patient. Almost 50 to 60% patient will develop either local as well as distant metastasis within the 5 years. And that's why there is an unmet need of a very good adjuvant treatment in this setting. This is a famous Anita study showing the benefit of adjuvant chemotherapy in non-small cell lung cancer, uh, showing 5% survival advantage over 5 years. And this is in the clinical routine nowadays. Whosoever is having high risk feature is receiving adjuvant chemotherapy. But we have seen failure with the first generation EGFR TKI in lots of trials. They didn't demonstrated any overall survival advantage. Though some trials showed disease-free survival advantage, but it was not converted into the overall survival advantage. We have number of these trials, and then if you'll see the meta-analysis of these trials, the DFS, there was 48% reduction in the disease recurrences, but overall survival, it was non-statistical significant. And that's why these therapies was not able to get FDA approval or EMA approval in this setting. And then we had this landmark study of ADORA trial, role of osimertinib in the adjuvant resectable non-small cell lung cancer carrying exon 19 deletion and L858R mutation. And the randomized patient, maximum interval between surgery and the randomization, 10 weeks if the patient didn't receive adjuvant chemotherapy, and 26 weeks with adjuvant chemotherapy. So they allowed chemotherapy followed by osimertinib, or in some patient, only osimertinib was given. They randomized 1:1, either osimertinib or placebo, and this was continued for the 3 years. And the follow-up was done until recurrences. The primary endpoint was the disease-free survival, and the secondary endpoint was DFS according to the stage-wise overall survival and health-related quality of life. This was the DFS Kaplan-Meier showing the hazard ratio of 0.23, which is very nice if we see in context of any oncological treatment, where I think there are very less trials which are showing the hazard ratio like this. In the overall population, if we see the disease-free survival was 65 versus 28 months, which is very significant. Another peculiar thing about osimertinib, as we know that it crosses the blood-brain barrier, and the chances of CNS relapse in this setting is also less when we give adjuvant osimertinib. Though the median was not reached in the both arms, but as we can see, it is very well separated. Talking about the side effect or the safety profile of the osimertinib, we know that compared to the first and second generation TKI, osimertinib is very well tolerated. If we see the drug discontinuation rate, it's only in 13% of the patient. While if we talk about the first and second generation, we have to reduce the doses. We know that it is having the more toxicity with the first and second generation TKI. So if we talk about the key takeaway from this, that we should identify the correct treatment. We should identify the right patient at the right time, and we should offer the right treatment to those patients. We should never miss an opportunity to test the actionable mutation, because we know that it makes difference, and multidisciplinary team approach is the key to improve the patient outcomes. And I think ADORA is very well accepted. And nowadays we are, I think, following it from the last 2 or 3 years. Thank you. This is it from my side.
Okay, thank you, Dr. Amit, for this talk. So let's resume. And for the next talk, I would like to invite Dr. Abhinav Gulyani, who is consultant associate professor SGRH Delhi. And the topic will be advances in diagnostic bronchoscopy.
So, thank you so much. I would like to thank the organizers for giving me an opportunity. And I'd like to request you to kindly share my slides so that I can start speaking about this newer changes which we are sort of seeing now in the diagnosis of lung cancer. What are the advantages, what are the limitations, and how can we basically proceed with the diagnosis of lung cancer when we see the patient in our OPD, and what else can be done for patients of lung cancer in this realm. Next slide, please. So I'll start off with a quote which I have stolen from Isaac Newton. I have seen further, it is by standing on the shoulders of giants. So that means that we are gradually and gradually advancing, And it is the basis of this is all history, where we started off with a simple bronchoscope. Next slide, please. When accidentally Gustav Killian went in with a tracheoscope. He was an ENT surgeon into the trachea to take out a pig's vertebra or a bone. And that is how the bronchoscopy was invented. And we have been gradually building up, building up. Next slide, please. On this. Uh, it was later that Shigeto Ikeda in 1967 introduced the flexible bronchoscope. And the flexible bronchoscope over the last so many years has advanced to now the miniscope, which is almost 3.1 millimeter in diameter, and it can access even the generation 5 or 6 bronchi, where we can see and take advantage of the small size. Obviously, all these come with the disadvantages as well. Next slide, please. So what basically rigid is when you put in a steel bag, the one you see in this picture, into the trachea and maybe the main bronchi. And with that, we can put all these instruments to take samples, to deploy stents, to deliver radiotherapy, and also to open up the airway when the airway is narrowed because of an ongoing tumor which is outside of the lumen. Next slide, please. The flexible bronchoscopy is basically when you put this little tube, which can basically go into the smaller airway or the distal airway, and access the peripheral parts uh, of the tree of the bronchial tree, and also reach the peripheral parenchyma to sample and also to deploy markers can be used for radiotherapy in lung cancer. Next slide, please. The instruments which we have available are gradually advancing. Now, in the early 2000s, what was introduced was an endobronchial ultrasound. So this is the curvilinear ultrasound, which basically is used for airway regions which are right next to the airway and just outside of it, where the larger airway can be accessed by this scope. So the outer diameter of this scope is around 6 millimeters. So the limitation is that it cannot go into generation 3 and 4 bronchi. And any lesions like this particular lesion, which you can see over here, right next to the trachea, can be accessed with ease. And with the curvilinear EBUS, we can even see our tool inside the lesion when we are taking the sample. What we sometimes can do is we can put in forceps, we can put in a cryoprobe to take bigger chunks and diagnose diseases like lymphoma also, which were earlier not being able to diagnose by this modality. Next slide, please. The next topic is radial EBUS. If you click on it, it will bring 2 more images. So radial probe EBUS is basically for peripheral pulmonary lesions, where this small extension can be sort of thrown out of the bronchoscope, and it goes even to the last or the distal most airway up to the pleura. And once you have visualized the lesion, can you click once, ma'am, so that the images appear? Yeah. So if it's a lesion like this, which is outside the realm of the proximal bronchi, you can visualize such a lesion with radial ultrasound, as you can see in the middle image. And then, as in the last image, you can see you can put in a tool like a cryoprobe to take a chunk out of it. And the diagnostic efficacy of such a procedure is nearly 80%. Next slide, please. This is now being advanced day by day by means of smaller bronchoscopes and access to peripheral airways. This is the robotic assisted bronchoscopy, wherein a robot is docked onto the endotracheal tube after intubating the patient. And just like a video game, you can use a joystick to advance the bronchoscope up to the generation 7 and 8 and even up to generation 9 bronchi, because the outer diameter is as small as 2 millimeter with a good working channel, good command on the airway. And you can put in various tools like a cytobrush or FNA needle or a biopsy lesion, a biopsy tool like a cryoprobe mini, which is about 1.1 millimeter, to take samples and increase the diagnostic yield. Of course, all this is not always used for every case. There are specific indications for different cases. A peripheral lesion which is large can only be dealt with a radial EBUS, but a peripheral lesion which is small as a 5 millimeter lesion requires more finesse and more accuracy. All these things, they add to accuracy. Next slide, please. So our aim is basically nodule access, to diagnose and sample the tissue, to stage and to treat in the same setting or to aid the treatment in lung cancer. So peripheral lesions, if they are small, they can be accessed via this modality, and we can sample it. We can do rapid on-site evaluation, diagnose them, and in the same sitting, if that is only the small lesion, we can ablate it by means of cryo or by means of radiotherapy with our tools. So that is how endoscopy has advanced in the initial diagnosis part. Next slide, please. Staging and diagnosis. Next slide. Staging and diagnosis can be combined in the same sitting by means of diagnosing a peripheral lesion. If the lesion is, say, in the right upper lobe and you have mediastinal nodes in the left hilum, you can, in the same sitting, or you should in the same sitting, use a linear EBUS to sample that lymph node and decide whether the patient is amenable for further SBRT or surgery in the same sitting. So our diagnostic pathway is basically based on the CT or the PET, where you can see lesions in suspected population, and we have to acquire more and more tissue for genetic analysis, as the other talks have are going to highlight, and the previous talk also highlighted the importance of genetic analysis. So we select the route by means of where the lesion is. If the lesion is in the central airway, we would use a bronchoscope and bronchoscopy based approaches to diagnose it. If it is in the peripheral, one third or two thirds, we will use a radial EBUS and other navigation tools, or even CT guidance during the bronchoscopy to enhance that our tool is in the lesion. And if it is in the, if there are mediastinal lymph nodes along with during that and they are suspicious, we would sample them with EBUS. If endoscopic yield is low or non-diagnostic, a guided transthoracic needle aspiration or a surgical biopsy is our fallback. Because no matter what we do, the yield for bronchoscopic pickup for all these things can be increased to up to 90%, but not beyond that. And 90% is also when you're using robotic bronchoscopy and image guidance. But CT guided biopsy always has a higher yield, but it comes with the fallback of more chances of pneumothorax, more chances of bleeding, and sometimes the lesion cannot be accessed. Next slide, please. So in staging of lung cancer, the role of endoscopy is basically in the invasive part of it, where you can do an endobronchial ultrasound, and with the same scope you can, when you put it in the esophagus, it is called a combined mediastinoscopy, and that has now replaced surgical mediastinoscopy as a part of staging for lung cancer. So this is what we would generally do. We would do an EBUS and an EUS with the same scope in the same sitting, and that would suffice for staging lung cancer. Surgically, this can be done by mediastinoscopy, anterior mediastinoscopy, or Chamberlain's procedure, or video-assisted mediastinoscopy, which is coming in, but that is invasive. We fit into the non-surgical part. Next slide, please. So conventional flexible bronchoscopy has all these tools which are available for us for diagnosis. So we can either take a cyto brush to take brush smears, we can take forceps biopsies, we can take cryo biopsies, we can even take bronchoalveolar lavage, which aids in the diagnosis of lung cancer. The advantages are it is widely available, it is low in cost, and also the chances of pneumothorax are much lesser than the CT guided biopsies. And if there is bleeding, in case it is a CT guided biopsy, the control of bleeding is not in your hand. But after a bronchoscopic biopsy, you can still try and control the bleeding. However, the limitation is that if a lesion is less than 2 centimeters, the yield drops down to almost 60% with just bronchoscopy. Next slide, please. Radial EBUS has increased the yield. It is basically reported to have a yield of around 60 to 75% at better centers like ours. We have a yield of around 80% with radial EBUS for peripheral lesions. And the limitation is the smaller the lesion and the more away it is from the bronchus, the yield drops drastically. Navigation tools can be added to it and to enhance the chances of your pickup of the malignant cells. Why? Because in cases where you cannot see if your tool is within the lesion or not, the chances of pickup become lesser. If you see that the tool is within the lesion, your yield becomes higher. So you can combine it with the augmented fluoroscopy or a C-arm fluoroscopy or a cone beam CT guidance, and that enhances the yield immensely. Next slide, please. So this is what we analyzed at Gangaram. We did a study for 356 patients over 7 years, and the overall diagnostic yield was around 80.3%. Mind you, we also included non-malignant patients in this study as well. Next slide, please. So EBUS TBNA is basically utilized for staging of lung cancer. This is widely available now. Most centers in India have it. And as an example, in the Delhi NCR region itself, there are around 130 centers doing EBUS. So the sensitivity is as high as around 90% and with a very high negative predictive value. It is minimally invasive and can target even lymph nodes which are around less than 6 to 5 millimeter as well. And you can uh, get many times additional diseases. Some patients who have cancer are immunocompromised, and in India, because tuberculosis is so prevalent, they have a recrudescence, and you get necrotic nodes, and we pick up TB in many of these patients in addition to doing staging. You can combine it with EUS, and this graphic over here represents what all nodes can be targeted, and most of them, except for the perigastric or periesophageal nodes, can be targeted by just EBUS itself. Some people have also sampled the adrenal gland using EUS or EBUS, and that is something which can be handy sometimes for staging these patients. Next slide, please. So if you compare it with the CT, the sensitivity and specificity of EBUS is significantly higher. And even if you get a normal mediastinum on CT, sometimes you can get nodes which are less than 1 centimeter, and the chances of that being malignant in lung cancer patient is around 19%. So upstaging the disease for the benefit of the patient. Next slide, please. So if you compare it with PET, the pickup for EBUS or the sensitivity for EBUS is much higher in patients where you do EBUS in addition to PET, and about 30% of PET positive lymph nodes come out to be negative, and 10% PET negative nodes come out to be positive by EBUS. Next slide, please. So this is tabulating the accuracy of various staging tests as mentioned in the previous slides, highlighting the importance of combining EBUS and EUS to enhance yield. Next slide, please. Next slide, please. So to maximize the diagnostic utility of EBUS, we can combine it with core needles, with the Francine tip needles, and also forceps or intranodal cryobiopsies during the same sitting. And as I highlighted earlier as well, this enhances the yield by manyfold. Next slide, please. So specimen handling is very important, and the goal is to acquire more and more material for the advanced testing. And this is sort of uh, bettered by using rows, by using some techniques by doing multiple passes, avoiding excessive smearing, preparing cell blocks, and obviously mapping the airway, mapping the nodes, and doing it under a deeper sedation. That also always helps. Next slide, please. Navigational bronchoscopy, as I said, by adding guidance with the CT and planning or making a virtual bronchoscopic map always helps. So electromagnetic navigation, which is presently not available in India, is something which comes in handy when you're planning this. So does robotic bronchoscopy. But the limitation is that all these things are very, very expensive. But that can be used in combination with the radial EBUS to help enhance the yield. Next slide, please. Uh, Next slide, please. So, what are the safety limitations and complication avoidance strategies when you are doing a bronchoscopic procedure to sample the airway? So, bleeding is the most common complication, but you can use local pressure, local vasoconstrictors to reduce the bleeding in most cases. Similarly, a pneumothorax is a common complication of a lung biopsy whenever you are taking one. But most patients would sort of not require a tube. Typically, uh, less than 2 to 5% would develop a pneumothorax, and 1% out of them would require a chest tube management after that. Hypoxemia, bronchospasm, infections, and fever are avoidable and manageable complications of bronchoscopy. Sometimes you have to sort of, some patients are on antithrombotics, and you have to sort of balance and weigh out the risks of stopping the antithrombotics and assessing whether a biopsy is needed and stop them to avoid the bleeding. Next slide, please. So if you compare this with CT-guided TTNA or surgical biopsy, this is much less invasive. However, the yield is lesser than both the above. But if the case is right, just bronchoscopy can get you a lot of tissue and sample and save a more costly surgery or a more risky CT guided biopsy procedure is what the data says. Next slide, please. So what is the practical algorithm is you would probably do a PET or a CT first, and then if the lesion is central or visible, you would do a conventional bronchoscopy with biopsy, brush or ball and TBNA. And if it is a peripheral nodule, you will go in with radial EBUS. If the lesion is small and pleural based, you can probably go in for a TTNA. And if everything fails, you will have to fall back on a surgical nodule biopsy in maybe 10 to 20% of the patients. But in most, you are able to diagnose with just bronchoscopy itself. Next slide, please. So the limitations are, as I discussed above, sometimes you need more material, and if you need more material, a different sampling method is what is recommended. There is a learning curve with all these procedures, and that is why centers who are handling such cases should be preferred. And in case you are not able to diagnose in the first setting, you have to probably increase your yield by referring to another center of more experience if surgery or other things are not in place. Next slide, please. So coming to the therapeutic part of bronchoscopy, it is not always just the diagnostics. In lung cancer, many times you need to recanalize the airway. In the first video, you can see an endobronchial tumor being cold and the airway being cleared with a rigid bronchoscope. In the second video, you can see a cryoprobe cryoablating a broad-based tumor where times you need after a biopsy in patients with carcinoid, this can be just therapeutic. Brachytherapy can be done, and palliative stenting in patients who have an airway compromise is also possible. We can even put stents through the scope, which are very, very narrow airways now, and that is also something which is not something of the future but of the present. Next slide, please. So take home points are: you match the tool with the with your diagnostic capability. If you want diagnosis, if you want staging, or do you want both, preferably both in the same sitting is what is recommended. Plan for molecular adequacy. You need good cell block, you need multiple passes, and you should know when you have to pivot from TTNA to surgery to avoid delays in care. A multimodal approach always helps. Whenever you are trying to sample a lesion, use as many sampling tools as possible to increase your yield. Thank you.
Thank you, Dr. Abhinav, for giving this wonderful talk. Now, let's resume to our next session. So, next talk will be given by Dr. Abhishek Kumar, who is consultant medical oncologist at Northern Railway, Delhi. And the talk will be on raising the bar for EGFRM and SCLC.
Am I audible?
Yes, sir.
Please allow me to share my slides.
Yes, sir, you can go ahead.
Thank you so much.
Are my slides visible?
Not yet,
Uh,
sir. They are still loading. Yeah, they are visible now. You can make it full screen. Sir, are you able to hear me? Dr. Abhishek?
am I audible to you?
Yes, sir, you are audible also. Just make your slides full screen.
Yashika, am I audible now?
Yes, sir, you are audible. And your slides are loading.
Actually, I have some net issues, I guess. Is it visible? Yashika,
No,
are my slides visible?
yes, sir, they are visible. Yeah. Sir, they are visible. You can start. Dr. Abhishek?
Audible.
Sir, you are audible, but your voice is breaking.
Mm. I don't know how to.
Yeah, now it's fine.
Give me a
So,
second.
so do you want me to share your slides? Maybe because of the network.
So the issue is my network problem. I don't know at this moment it happened. Fine now.
Yeah, they are fine.
So we all know that the EGFR mutation positive, the prevalence rate in Asian and non-Asian subgroup is in non-Asian it is around 20%, and in Asian subgroup the EGFR mutation is around 40%. The incidence rate in our Indian subset of population is around 33 to 39%. And these EGFR is nothing but the cell surface receptors which have the tyrosine kinase domain. So once these EGFR receptors get mutated, there is a constitutive tyrosine kinase activity which results in the intracellular signaling pathways and continued cell proliferation. So the most common EGFR mutation is exon 19 deletion followed by exon 21 L858R mutation, point mutation. So the mutations range from exon 18, 19, 20 to 21, and it also includes other atypical mutations, including the exon 12 mutations of EGFR receptor. Now, the current outcomes with TKI in terms of overall survival, we can see the first generation Geftinib and Erlotinib, the TKI, the overall survival was limited to 22 months. And as we progress to the second generation, to the third generation TKI, that is the Osimertinib, in which the FLORA trial has shown the median overall survival of around 38.6 months when the Osimertinib was used in a monotherapy in metastatic non-small cell lung cancer. So is there a need for any combinations therapy to combine these TKIs with chemotherapy? I would say definitely yes. There is definitely a need to further improve the outcome in EGFR mutated patients. We can see that the patients who are continuing to receive the first line drug at 2 years with osimertinib is around 42%, with the first generation TKI it is 16%. And when it goes to 3 years, the percentage of the patient receiving the first line drug is 28% in the osimertinib arm as compared to only 9% in the patients who are receiving the first generation TKIs. So we can see that very few patients remain in the therapy after 2 years. So I would say definitely there is a need to improve the outcome, which can combine the TKI with the chemotherapy. So will the addition of chemotherapy to the EGFR TKI helps to improve outcomes? So there was two studies which were being done by the name NEJ009 trial, and also we have a TMS study which has shown that when Geftinib, the first generation TKI, was combined with chemotherapy in the treatment naive EGFR mutated non-small cell lung cancer, there was a significant improvement in the progression-free survival. In NEJ009, it has shown when Geftinib was used, the median PFS was around 11.2 months, but when it was combined with the chemotherapy, the median PFS gets rose to around 20.9 months. Similarly, the study of TMH study also shown the increase in the median PFS when Geftinib was combined with the chemotherapy. So what are the key questions in selecting the treatment? First of all, definitely the efficacy, whether the combining the treatment will improve the PFS, overall survival, their CNS efficacy, the co-mutations, the mechanism of resistance. Will the patient able to tolerate the combination of EGFR TKI and the chemotherapy, the patient's comorbidity factors, their performance status, and of course the patient preference as well. So now today my focus will be on this FLORA2 study design, which was a phase 3 open label randomized study of osimertinib with or without platinum pemetrexed in first line non-small cell lung cancer. In this study, the patients who were locally advanced or metastatic non-small cell lung cancer with age more than 18 years, and in Japan more than 20 years, who were EGFR mutated exon 19 deletion or L858R mutation, who were treatment naive. And in this also the patient who were stable with having stable CNS metastasis were also included, and with the PS performance of 0 to 1. So in this patient, they were given in one arm osimertinib along with the chemotherapy. In other arm, it was only osimertinib. So in the arm with combination therapy, the osimertinib 80 mg OD plus chemotherapy, pemetrexed 500 mg per meter square Q3 weekly, along with the cisplatin or carboplatin for 4 cycles they have received, followed by the maintenance therapy of osimertinib and pemetrexed. In other arm, there was a osimertinib monotherapy, that is osimertinib 80 mg OD. The primary endpoint was the PFS and the secondary endpoint was PFS2, overall survival, duration of response, safety, and health-related quality of life. So this study was a multi-center study. There are around 887 patients were enrolled from various studies. So this red color shows the patients who were heavily enrolled. So it was a multi-center study. Across the 21 countries were included in this study. The baseline characteristics in both the arm, that is the osimertinib along with the chemotherapy versus osimertinib monotherapy, were adequately matched, and as expected, the females were more common because we all know that the EGFR mutations are more common in females. So around 60% of this in this trial were among females. As we can see, also the patient EGFR mutations are more common in non-smokers. So patient who were never smoker were around 67%. Mostly patients were adenocarcinoma, 99%. And the other thing to mention here is the patient who were having the stable CNS metastasis were around 40% in this trial. So the 40% of the patient had CNS metastasis at the baseline. But we can see in the progression-free survival, when the combination arm of OSI plus chemo was compared with the osimertinib monotherapy, we can see the early separation of lines within the 3 months only. So there was an early separation of graph, and the median PFS with the addition of chemotherapy with osimertinib was tremendously improved, and it was median PFS was around 25.5 months as compared to 16.7 months in the osimertinib monotherapy arm with HR of around 0.62. So there was a median PFS benefit of around 8.8 months when osimertinib was combined with the chemotherapy. As we can see by the BICR data also, the median PFS advantage was there, and that median PFS benefit was of around 9.5 months. Now in the forest plot analysis, we can see that the PFS benefit was seen across all the subgroups, irrespective of the sex, race, whether EGFR mutation were exon 19 or L858, or about the performance status. And the point to highlight it here is that the patient who were having the baseline CNS metastasis, they also benefited much with the addition of chemotherapy along with the osimertinib. So HR ratio in those patients with CNS mets were around 0.47. Now, in terms of the overall survival also, we can see that with the addition of combination therapy, chemotherapy with osimertinib, around 63% of the patients were alive at 3 years as compared to 51% with the osimertinib monotherapy. And in 4 years, around 49% patients were alive with the combination therapy as compared to 41% with the monotherapy. So the median overall survival was improved with the combination chemotherapy. Just a minute. Oh my God, what happened? So the combination therapy, the median overall survival was around 47.5 months as compared to 37.6 months with the osimertinib monotherapy. So there was definitely improvement in the median OS of around 9.9 months with the addition of chemotherapy with osimertinib. Now in the forest plot also we can see that this overall survival benefit was seen across all the groups. And in terms of PFS2 also, the patient when progressed after the first line, then also the PFS2, there was a benefit in the combination arm with osimertinib chemotherapy. So the PFS2 was around 30.6 months with the combination arm as compared to 27.8 with the osimertinib monotherapy. Now, in the forest plot also, we can see that the combination receipt of osimertinib and chemotherapy, the objective response rate was 83% as compared to 76% with the osimertinib monotherapy. And the median duration of response was also improved, and it was around 24 months with the osimertinib with chemotherapy as compared to 15.3 months with the osimertinib monotherapy. And in terms of the PFS in patient with the CNS metastasis, also there was an early separation of graph at 3 months. The median PFS was around 24.9 months in the combination therapy as compared to 13.8 months with the osimertinib. In terms of the CNS PFS, also there was an advantage with the combination therapy. Now we can see about the response rate. In terms of the CNS response rate, the CNS overall response rate was around 88% with the osimertinib with chemotherapy as compared to 66% with the osimertinib monotherapy. And the complete response rate with the combination therapy in terms of CNS response rate was around 48% as compared to 29% with the osimertinib monotherapy. Now, we can see that the probability of observing the CNS progression at 2 years was 23% with the osimertinib monotherapy, and that significantly declines to only about 9% when the patient has received combination therapy. So definitely the chances of CNS progression was definitely reduced when the combination therapy was being used. Now, in terms of the exposure of the chemotherapy arm, we can see in the combination arm with the osimertinib and chemotherapy, the platinum exposure duration was around 2.8 months. That was around for 4 cycles. So platinum was exposed to only around 2.8 months. And in those arm only, the pemetrexed was continued for around 8.3 months. So the osimertinib total duration was around 30.5 months as compared to osimertinib monotherapy that was around 21.2 months. So the median duration of osimertinib exposure in the combination arm was 9.3 months longer than the osimertinib monotherapy arm. In terms of the subsequent treatment in the FLAURA2, once the patient has progressed, we can see the most of the patient has received the chemotherapy, both whether in the combination therapy or in the osimertinib monotherapy, and that chemotherapy most common was platinum agent. Now about the safety analysis, definitely the side effect toxicity profile was higher with the combination arm in term as compared to the osimertinib monotherapy in terms of anemia, diarrhea, nausea, and so on. However, there were no new safety signals were observed when osimertinib was combined with the platinum-based chemotherapy. And we can see from these bar diagrams also the kind of toxicity profile in the combination therapy was higher during the induction phase of the chemotherapy. That anemia, thrombocytopenia, neutropenia, or various other side effects were more common during the 4 cycles of platinum with pemetrexed. So they were more common with during the starting 3 months, and they gradually declines after. So we can, if we compare the FLAURA and FLAURA2 trial, we can see that in FLAURA2, there was an improved PFS in all comers. The combination arm, the PFS was around 25.5 months as compared to 16.7 months with the osimertinib monotherapy. In terms of overall survival, also in the combination arm, the median OS was around 47.5 months in the combination arm as compared to 37.6 months with the monotherapy, osimertinib monotherapy. And in terms of the CNS Mets also, the PFS patient having CNS Mets, in those patients also there was a significant PFS advantage. The PFS in those patients were around 24.9 months with the combination arm as compared to 13.8 months in the monotherapy arm. As I said, definitely the side effect profile were higher with the combination arm, but they were more common during the induction phase, that is during the starting 4 cycles of the chemotherapy. And also there was an improved response in the patient who were having L858R mutations. In those patients also, the survival was around 24.7 months as a PFS versus 13.9 months with the osimertinib monotherapy. So in the final slides, I would like to conclude that osimertinib plus chemotherapy definitely demonstrated a median overall survival of nearly 4 years, approximately 47.5 months, as compared to 3 years, that is 37.6 months with the osimertinib monotherapy. So with over 2 years additional follow-up since the primary analysis, the safety profiles remains manageable and expected. So this overall survival result from the FLORA 2 definitely suggests this combination therapy, that is osimertinib with chemotherapy, as a first line standard of care in the EGFR mutated advanced non-small cell lung cancer. But the patient selection is definitely important, whether the patient can able to tolerate those combined therapy or not. So that is my final slide. Thank you.
Thank you, Dr. Abhishek, for this wonderful talk. We will be taking questions at the end of the conference. So let's begin with the next session, that is panel discussion on redefining EGFRM stage 3 NSCLC management. So it will be moderated by Dr. Sajjan Rajpurohit, who is Senior Director Medical Oncology, uh, BLK, and let me invite the panelists. So Dr. Amit Badola, who is Consultant Medical Oncology, Max Super Specialty, Dehradun. Dr. Nitin SG, Consultant Medical Oncology, Fortis Vasant Kunj. Dr. Disha Tiwari, Consultant Medical Oncology, Max Hospital, Vaishali. Dr. Rachita Huja, Assistant Professor Radiation Oncology, Shri Guru Ram Rai Institute of Medical Sciences, and Dr. Amit Sehrawat, Associate Professor Medical Oncology, AIMS Rishikesh.
Thank you so much. And can we have the presentation slides put up? Next slide. Okay. So we know that stage 3 lung cancer is definitely a very heterogeneous kind of population, where we have some patients who might actually be resected upfront. Then there could be other patients who are candidates for CTRT. There have been some good trials with the neoadjuvant chemoimmunotherapy followed by surgery. So we have a lot of data in this subset of patients where we have stage 3A, which is around 20% of patients, and we also have around mostly stage 3B patients. And if we talk about the surgical part, most of the stage 3A patients will get some form of surgery, either upfront or after chemo radiation or after chemotherapy alone. So it is a kind of stage 3 is a kind of the stage where multidisciplinary treatment is very important for our patients. Next slide. So now we talk about this is the kind of the incidental N2. So we could have patients where the patients could have an incidental N2 where the surgery has been done, and then on surgical staging, the patient is found to have N2 disease where there was no initial workout, either with the PET scan or with mediastinoscopy or EBUS, not showing any N2 disease, but on the final resection there was N2. These patients are actually put up for adjuvant therapies. Then there are patients who are potentially resectable N2. There we have a MDT where surgical multimodality treatment is being done. And there are unresectable N2 disease where again non-surgical modality treatments are being done. So if we talk about stage 3A, 3B and C3, the median survivals, if we just talk about 3A, the median OS is actually 41.9 months. And then from 3A to 3C, the median survival decreases to 11 months. So that could really be very, so a same stage median survivals are almost 4 times higher in stage 3A compared to 3C. So it's very important to choose wisely what could be the sequence of these treatments. Next slide. And obviously, I like to ask now I'll start with the Dr. Amit Badola. Dr. Amit, so for a patient who has got a PET scan done, biopsy proven non-small cell lung cancer, it looks like there's some mediastinal nodes which are there, which are not very big in size. So possibly a 3A or could be a 3B stage clinico-radiologically. How do you proceed with such patients? Dr. Amit.
Good evening, sir.
Good evening. Good evening.
For a fit patient, stage 3A, now if the patient is fit, we can go with the, after doing this molecular test, EGFR, ALK, and PDL1. I would like to proceed for the neoadjuvant chemo IO for a fit patient where we can consider surgery in future. But before that, I would like to do the mediastinal staging as well to confirm it whether it is a N1 or N2 disease. And
Okay.
the most important is the patient-related factor. If the patient is fit, then only we should do all these things.
Okay, so patient factors, and then Dr. Nitin, the patient is found to have so a proper EBUS is done, and there is a minimal N2 disease, and the N2 doses are not bulky, but then on EBUS the N2 stations are positive. So there's one N2 node which is positive, and patient is otherwise fit. So in such a patient, what will be your approach? The patient is fit. There are no financial constraints for this patient. The patient has come to you. You have taken the patient to multidisciplinary meeting. So,
Yes, sir.
would you be keen to go for anterior therapy? If yes, what will be your regimen? Number one, or the surgeon feels that no, I will like to do the surgery first and then take the patient for adjuvant chemo plus minus immuno. Number two, then I'll go to the other questions. These two questions.
So, sir, definitely patient's PS and age and everything does matter. And mediastinal staging, as you told, it's not a bulky N2. If it is bulky or multi-station, definitely I would consider restaging, proper staging, not just based on the EBS, if possible, mediastinoscopic staging. But yeah, if it is non-bulky N2 only, I would always push towards a perioperative neoadjuvant or perioperative chemoimmunotherapy if the patient is fit and otherwise there is no financial constraints. And my go-to combination would be platinum doublet with nivolumab.
Nivo plus platinum doublets.
Yes,
Dr.
sir.
Amit Sherawat, with your vast experience, would you agree with Dr. Nitin, or your approach will be different, or would you incorporate some more biomarkers before you choose?
Hi, sir. Good evening. First and foremost, a few disclosures. So whatever I am going to discuss is theoretical only because I am working in academic center with the limited finances for the patients. So most of the
So,
time,
so
graduate-
if
Yeah.
you have the academic knowledge of AIMS, and suppose a patient has come from a private center for second opinion from you, and they can afford everything in their life. So now, what would you assess them?
Yeah, so other than this routine test, I will also like to offer at least limited gene panel testing. At least EGFR should be available when we are planning to treat such patients. So,
Okay.
for example, this is known that EGFR and ALK, they are relatively marker for immunotherapy resistance. So even if
Okay.
you are planning for, say, neoadjuvant ICI, so that information might help us in making our decision in such group for the patient. Also, so that will be kind of additional thing that I would also like to have a look at before offering neoadjuvant chemoimmunotherapy.
Okay. Dr. Disha.
Hello, sir.
Uh, Yeah, I'm Ray. So I want to just confirm with you, are you a medical oncologist or a radiation oncologist?
I'm consultant medical oncologist in Max Vaishali.
And we also have a panel, we have an expert panelist who is a radiation oncologist. Is Dr. Rajit? Rachit is medical oncologist, radiation oncologist.
So good evening. I'm a radiation oncologist.
Okay, okay.
Yeah.
Now first to you, so Dr. Disha, now why if a surgeon is very confident that they can do the surgery, would you like to convince them, or you find that they take the patient for surgery? Number one. Number two, what will be your your comment on this, that why would you like to take this patient for anterior therapy? What will change in this patient if the patient undergoes surgery followed by adjuvant therapy versus neoadjuvant chemoimmunotherapy followed by surgery?
So if we are opting for the neoadjuvant chemoimmunotherapy, definitely we know now the trial has also shown CheckMate 770 that we do have a good PCR rate, and with the immunotherapy, and if the patient is biomarker negative EGFR and ALK especially, we can give him the benefit of this immunotherapy in the adjuvant setting for 1 year as well. But having said that, personally, I am still not very confident about this upfront surgery approach. A, we don't have much data about it. B, we don't have personally, we don't have enrolled too many patients in the upfront surgery, basic perioperative, I would say, not the upfront surgery. We haven't enrolled much patient in the perioperative setting as of now. Do I have enrolled few patients, 1 or 2? So not very confident for N1 patient. Definitely, I would advise do an MDT. Advise we can go ahead with the perioperative approach. But for N2 station, I am still skeptical for this perioperative approach.
Okay. I take your points now, Dr. Rachit. You are also there as a part of panel. So,
Yes, sir.
which side you would be on? Medical oncologist, or you will say, no, I think chemo radiation also good enough. I'll go for chemo radiation followed by adjuvant durvalumab for 1 year. So, what would be your take in such a patient?
Sir, we would take the patient to MDT. Ultimately, the patient has to be at the center and not any particular specialty. If the MDT agrees to a surgical approach for the case, then yes, the patient should go for the surgery. If it is technically non-resectable, or if there is any contraindication medically, or the patient party disagrees for the surgery, then yes, definitely CRT followed by durvalumab, or if there is a driver mutation for EGFR or ALK, then that should be given as a maintenance.
Okay. So actually we are a part of this MDT only. So now I'll
Yes,
go
sir.
to Amit back. Amit, so if we all are MDT, unfortunately I don't have a surgeon because otherwise I would have really got a surgical opinion also. So Amit, perioperative chemoimmunotherapy, the data is really promising. In fact, we have had many talks and meetings where we've been trying to convince our surgeons that even for probably a small tumor which is not negative sizes T2B or more, we might actually opt for perioperative. So how convinced are you with the perioperative chemo immunotherapy? That's number one question. And what is happening at your center? Are your surgeons really keen to take up perioperative chemoimmunotherapy in their practice?
To be very frank, if surgeon का बस चले तो वो सबकी surgery पहले ही कर दें. But I'll be more inclined to a perioperative approach because we know that it is an immunogenic tumor. So if the tumor is inside the body and we are giving immunotherapy, it will respond really well. And we have seen the pathological response is as equal to triple negative breast cancer, approximately 40%. And the major pathological response is more than that. So even if the patient is borderline operable or operable, I would prefer to go with the neoadjuvant chemo IO because all these patients, more than 90% patients were able to underwent surgery and the disease does not progress. So I'm very comfortable of going with neoadjuvant chemo IO because after surgery, sometimes we are not able to give or complete our treatment. Though we have a data of both neoadjuvant or perioperative or adjuvant chemo IO.
Okay. So next slide, please. Next slide. Next slide. Okay, I think one point I want to really drive is that we have had multiple meetings across, in fact, MDTs kind of things where we had medical, surgical, radiation oncology. And one thing which we've been trying to drive home is that perioperative immunotherapy might be actually a good approach, especially for patients where we are trying to resect the disease. That's one thing. So that was a scenario. If the patient is 3B or 3C, so Dr. Amit, Dr. 3B, 3C, chemo radiation followed by immunotherapy, or would you like to have some therapy before you take it for radiation? Dr. Amit.
For 3B or sorry.
Which Amit sir? Dr. Amit sir,
Amit Sharavat. Amit
Yes.
Sharavat. Yeah, Amit Sharavat. Yeah, sorry.
Yes, so by default, most of the patients, they end up getting neoadjuvant approaches first, even if you are planning for radical CTRT. So
no, but that's because the waiting time is long at your center. But now, if it is not by default, the patient is 3B, it's a bulky node, N2 disease is there. And then again, I just ask you, like, radiation is accessible at your center. Probably the patient can be started on radiation as soon as 3 to 4 days. So would you still take them for neoadjuvant, or you will call up Rachit and ask him to take up the patient?
Yes, sir. Even with that, if dates are available and if there is heavy disease burden, so that option of offering neoadjuvant ICI approach is going to be one of the potential strategy for such patients.
Okay, now I'll take it, Rachit. So do you agree with Dr. Amit Sherawat, or you have a different thought on this?
So I would agree, but I'll be a little bit skeptical regarding immunotherapy being given prior to radiation. My skepticism relates to both radiation as well as immunotherapy causing pneumonitis. So that might be an issue to me for radiation. But yes, for a bulky N2 disease, we would also sometimes might just go for neoadjuvant chemo that might give us better dose controls for the organs at risk.
Okay, okay.
Yeah.
Next slide, please. Next slide. So, if we talk about the Asian consensus, so non-metastatic unresectable lung disease, the patient is fit for definitive chemoradiation. Then we have to check for PD-1, PD-L1, and EGFR. Now, if the patient has got EGFR mutation positivity, then we have to go for the recommendation would be actually to just take it further. And we have 3 classes. Next slide, please. I'll just show you the next slide. Next slide. Okay. So now there's a lot of literature where the completion of CTRT actually varies to a lot in these. Can we go back one slide back? One slide back. One slide back. Okay. So if now here resectable, we can actually go for neoadjuvant chemoimmunotherapy. We could go only for neoadjuvant chemotherapy, or we could actually go for neoadjuvant chemo radiation and then take it for surgery. And then once the patient has been resected, then patients who did not receive neoadjuvant chemosystemic therapy, they could be offered adjuvant chemotherapy. Patients who are EGFR positive could be offered adjuvant osimertinib. Patients who had mediastinal N2 nodes and did not undergo any radiation in the front could be offered post-operative RT. So this is of patients who are potentially resectable. Now coming to the other part, which I was asking you again and again. So unresectable, if the patient, their performance status is good, then most of the patients actually are candidates for concurrent chemotherapy and radiation. That's how the current practice is. And then obviously once this is done, then we can actually have the adjuvant, we could actually have adjuvant, if the patient is EGFR positive, we might only give consolidation with osimertinib and not add immunotherapy. And if the patient is not EGFR, in fact, I would also like to add ALK, because if we get ALK also, it is unlikely to benefit from durvalumab. So right now they are not a part of guidelines. But if ALK is also positive, probably giving a ALK inhibitor might be better to these patients, because most of these patients who are ALK positive will most likely systemically fail. So if in my practice, I'm actually doing is that getting a EGFR and ALK to begin with, and once chemo radiation is over, then we would like to put them on adjuvant osimertinib for 1 year, or probably ALK inhibitor also put for 1 year. And if none of these are there, then durvalumab for 1 year. So that's the kind of situation which we're having. If the patient is not fit for chemo radiation, then we could actually have a sequential chemotherapy and radiation. And patients who are not candidates for chemotherapy, radiation alone. So this is the kind of guidelines which are mostly being followed. Now, also part of NCCN. Next slide. Next slide. Next slide. Next slide. Let's go to the case. Next slide. 62-year-old lady present with persistent cough, no history of hemoptysis, no history of smoking. Baseline CT scan was done, showed a lesion. Next slide. Baseline PET also showed that there was a local disease, and there was N2 station disease also was there. Local regional disease was, you can just see on the PET scan, there was a T2B and N2 multi-station disease was there. MRI was normal. Next slide. So I'll come back to you again. So let me go to Dr. Disha. Dr. Disha, I've shown you the guidelines. Now, such a patient, what will be your choice? The patient has got EGFR positivity. Okay, the patient is EGFR positive. How would you approach such a patient?
So then I would start with the chemo radiation followed by osimertinib for this patient, definitely, if the patient is EGFR positive. So What you have said, we are also following this only, that we do advise EGFR and ALK as well. If the patient is EGFR or ALK positive, we don't give durvalumab consolidation. If the patient is EGFR or ALK negative, only then we go ahead with the immunotherapy consolidation. If this patient is EGFR positive, then definitely I would go for the osimertinib in the adjuvant setting.
Okay, next slide. This patient actually was given chemotherapy. After 2 cycles, there was some induction chemotherapy was given. The patient had some reduction. Next slide. Patient received concurrent chemoradiotherapy. Next slide. Now I'll go to Rachit. Rachit, what is your understanding of these patients, 3B patients? How many of your patients, among the 100 patients you recruit, how many patients actually are able to complete your full course of chemoradiotherapy?
Sir, I would say at least 80 to 90% patients are able to complete radiation. Concurrent chemo at a weekly dose also, not more than 4 or 5. All the 6 weeks of chemotherapy, it is difficult for the patients to complete. So I
Okay.
would say chemo somewhere to the tune of 70 to 80% and radiation at least 80 to 90%. That is what we at least push for.
Okay. Next slide, please. So have I involved all the panelists because Yashika, some of the panelists, all the panelists have involved or some more panelists were there as a part of this?
No, sir. You have involved all the panelists.
Okay. Thank you. So, so as I mentioned, now we have a lot of data with adjuvant post chemotherapy. There have been adjuvant consolidation with docetaxel, docetaxel. There have been chemotherapies. There have been drugs like geftinib. There have been drugs like cetuximab. All these trials have failed. Next slide. Next slide. Now, Pacific, we all know that was the first positive trial. Again, a landmark trial because we hardly had any patients who could really be offered after post chemo radiation. We would just wait for these patients to either get cured, which will happen only 25-30% of patients. Most of these patients would actually end up with metastatic disease within 6 months, and that would lead us to go to metastatic setting. But now, after Pacific with durvalumab, we have the data from Pacific. Next slide. And this actually showed that at 12 months, 24 months, 36 months, 48 months, and even at 60 months, the PFS was around 33%. That means there's a huge benefit of adding immunotherapy in patients, especially if the patients are non-target driven, to just leaving them alone. And this was like kind of a landmark trial, and which has actually been a practice-changing trial for us. And I would agree that all of us are quite keen to add durvalumab. So, Dr. Amit Sherawat, so how much convincing is Pacific for you? Do you routinely recommend your patients to take up durvalumab in the adjuvant setting?
Yes, sir. So this was one of the first landmark studies which actually changed a few things when once we are completing CTRT. So that's one of the landmark reference studies. So obviously, since then, data is also confirmed from real world scenario also. So there is no doubt that this strategy is effective. But over a period of time, we also realize that certain subset of the patient, for example, EGFR and ALK, they are not ideal candidate for this kind of approach. But by default, most of the patients, they are at least getting counseling to start with adjuvant durvalumab post CTRT, even in my AIMS Rishikesh OPD.
Okay. So, Dr. Disha, has been your challenge with durvalumab in adjuvant setting? So, what are the challenges you have faced in your practice?
Apart from the financial challenges, sir, nothing is really very challenging in the adjuvant setting. Durvalumab is very well tolerated. Hardly few cases I've seen of pneumonitis aggravating post chemoradiotherapy. But those cases, if we talk about and if we take the whole combined pool of the patient, that those cases are negligible. So it is very well tolerated drug, and we do recommend this thing regularly. If there is no financial challenge, then I would advise durvalumab. If the patient is molecular testing ALK and EGFR negative, then definitely going ahead with the durvalumab.
Dr. Nitin, do you agree with Disha or you have some different opinion? Dr. Nitin.
Hi, sir. Yeah, I do agree with Dr. Disha. So, durvalumab is quite tolerable by most of the patients. Only concern is pneumonitis. So I had two patients who had very severe pneumonitis post CTRT and on Durva. And we had to actually, in one patient, we had to permanently stop the durvalumab infusion. Otherwise, in general, it's quite tolerable, sir.
Dr. Amit Badola, what is the time recommended to start durvalumab post CTRT?
In trial, though, they have mentioned after 2 weeks or 4 weeks, but we are starting durvalumab 4 to 6 weeks. But I think in trial, they as early as 2 weeks they are started.
Yeah. As early as 2 weeks was recommended. Though most of us tend to start at 4 weeks because many of these patients who are just completing their chemo radiation are not that very in a good performance test. Sometimes PS decreases, and then we would like to them to be nutritionally better and then take up. But yeah, it is sooner the better for these patients. So next slide. Next slide. This the same slide shows that even there was a OS benefit, and that also was highly significant even at 5 years. Next slide. Next slide, please. Next slide. Oh no. I think we are to conclude that based on these data, Pacific durvalumab consolidation has been the global standard of care after this and demonstrates a significant and durable OS benefit. And this is one of the large trials which has shown benefit. And then again, we also know that EGFR mutant patients do not derive that benefit from immunotherapy. So that's an unmet need. But now we also have next slide. Next slide. So now we have adjuvant osimertinib data post CTRT, which now show that this could be a good option for them. Now, next slide. Quickly, another case: 52-year-old male non-smoker, left pulmonary lesion with hilar miraceran nodes, and no other risk factors or no other comorbidities. Next slide. Adenocarcinoma, PD-L1 0, PD-L on lung biopsy, but on EBUS, there was a PD-L1 of 80%. NGS EGFR del19 was found, and T4N3 disease was there. So there was a discordance in the primary versus the nodes in PD-L1 status. Next slide. I don't know why they always start with chemotherapy, but this is a case not provided by me, but then chemo radiation. Next slide, chemo followed by chemo radiation. So now we have both PD-L1 positive as well as EGFR positive patients. So patients in your practice, and how do you manage them?
So this patient is having EGFR mutations already. Biomarker is positive, hence there is no significance of PDL1 in this case. So I would be going ahead with adjuvant osimertinib following definitive CTRT.
Okay, next slide. So we have the LAURA trial. Next slide. And again, this was a large randomized trial, 2:1 randomized to osimertinib versus only placebo in these post-CTRT patients. And next slide. And the baseline characteristics were well matched. Next slide. Next slide. And now just hold here. Now, if you just compare to durvalumab, you see the PFS difference here. It's like staggeringly different in the patients who have been exposed to osimertinib. And then, so as Dr. Amit Shah was telling you, that Pacific was a practice-changing trial. I think this is kind of an outstanding trial for a drug in adjuvant settings. Dr. Amit, I'll come back to you again. So how do you see about LAURA in this adjuvant study?
Yes, sir. So this is also kind of unprecedented kind of results that we have seen with oral therapy in adjuvant setting in any kind of malignancy as such. So this is a kind of practice-changing landmark evidence. And again,
Yeah.
the difference in intervention arm and the control arm is huge. So even if there are certain issues with the trials design and settings, you cannot ignore that kind of difference. So by
hazard ratio of 0.19, hazard ratio and hazard ratio of 0.19 is definitely a kind of a really landmark trial for such patients. Next slide.
Never have any chance. So that means it's actually practically this is one of the most important message that adjuvant setting, if patient is candidate, this should be a standard of care.
Yes. Next slide. And if you just see almost all across all the patients, age groups, races, smoking history, the type of EGFR mutation, Chinese, non-Chinese, all the patients benefited in this. And there was hazard ratio. If we just talk about each of them are actually less than 0.5, which is really very nice because in the overall hazard ratio was 0.19. So that was definitely favoring the osimertinib adjuvant arm. Next slide. And the same waterfall plot also shows that there was a huge benefit with osimertinib compared to placebo. Next slide. And in fact, the new lesions which actually came up in these patients, so it also prevented a lot of brain metastasis coming to lung, liver. So there was also benefit in not only preventing metastasis, but also a pivotal area which was prevented was brain metastasis. Next slide. Next slide. OS data is still coming up, so I think in some more time we'll have OS data, but still because osimertinib was later received on later lines. But even after this, hazard ratios are still favoring the experimental arm of osimertinib. Next slide. Safety as was expected, there was well tolerable. There were not much difference in the previous recorded compared to this adjuvant osimertinib. Next slide. Next slide. I think we just can skip this. Next slide. Next slide. Now, one more concern has been definitely osimertinib also has been with pneumonitis. So now I'll go to Dr. Rachit. These drugs, do they add to the pneumonitis post-radiation? And what has been your concern when your patients come to you post-radiation on osimertinib, and then we are not very sure whether there's a disease progression, there's a pneumonitis, or this is post, sometimes it is labeled as post-radiation pneumonitis. So what is your take on pneumonitis?
Certainly, that is a huge concern for us. So first, our preference is always to start any sort of maintenance therapy at least after a gap of 4 to 5 weeks post completion of CTRTs. So we should wait for the acute radiation pneumonitis to settle.
Okay.
Second, this is definitely overlaps to actually differentiate what is the main cause. Sometimes radiation-induced pneumonitis also is prolonged. So that becomes a issue. Although I have not been fortunate enough to use osimertinib as a maintenance therapy in a large group of patients, so I really do not have that type of exposure. But then yes, that certainly is a definite theoretical concern.
Okay, next slide. And I think that's what is recommended here also. So durvalumab for adjuvant in patients who are non-EGFR positive, and osimertinib in patients who are EGFR positive, and now a part of standard guidelines in the NCCN. Next slide. So now I'll go to so Dr. Nitin, how do you have a follow-up of these patients? When is the first scan you do? Is it at 3 months, or you do it later, or you do it earlier? So and how do you follow up these patients for checking for metastasis? Dr. Nitin, you're there? Dr. Amit? Dr. Amit Barola.
Yes, sir. So post-radiation, sir, as Dr. Rachit said, we are not, suppose the patient is having driver mutation positive, we don't want to start osimertinib very early, at least 4 to 5 weeks. And then I think first scan, if we are using durvalumab, then I think we have to do first scan after 28 days. So to confirm that the disease didn't progress on chemo radiation, because that was the inclusion criteria in that trial, Pacific trial. But after that, when the maintenance treatment has started, so I would like to, and we are doing that in our clinical practice also, in first year, once in a 3 month or 6 months, and then 6 monthly with HRCT. and then I think annual PET scan.
Okay, next slide. So I think we had covered all the important topics in stage 3, starting from perioperative chemoimmunotherapy to adding consolidation with durvalumab to versus adjuvant osimertinib in subset of patients. So to conclude, in fact, EGFR mutation testing is an important part now of uh, managing patients with stage 3. And that definitely, again, if you just talk about 39.1 months PFS versus 5.6 months, and definitely there's a landmark trial here, the LAURA trial. And with this, I think we now are more clear about how to manage our patients. But definitely, stage 3 is the patients who require multidisciplinary meetings. And definitely, our surgeon has got a big role also. And we need to make our surgeons understand that many times surgery might be incorporated later than sooner, and they can also wait for overall outcomes of the surgery to improve. So with this, I'd like to thank all of you for actually participating, and thanks and back to the organizers. Bye.
Thank you, Dr. Sajjan, for moderating this panel discussion. So let's move on to our next talk, which will be given by Dr. Ankit Batra, who is Associate Professor Medical Oncology, CRI HIMS, Dehradun. And the topic will be all strategies in the management of ALK plus NSCLC.
Thank you, Yashika. I hope my slides are visible.
Yes, sir, they are visible. Kindly make it full screen.
Yeah. Yeah. So, very good evening, everyone. And at the outset, I would like to thank Dr. Chandra sir and Dr. Amit for organizing this webinar on the cancer management. I'll be speaking about the ALK strategies in the management of ALK positive non-small cell lung cancer, the base of ALPHA trial. So, just a brief overview of the disease. We know that lung cancer is most commonly diagnosed cancer and the leading cause of cancer mortality. We know the Globocon data. Incidence is more than 2.5 million cases, and mortality rates are much higher. That is 1.8 million deaths. So, if we talk about this subtype of lung cancer, which is non-small cell lung cancer, so this accounts for 80 to 85% of the cases, and it is highly heterogeneous. And in the era of precision oncology, precision medicine, with the availability and accessibility of NGS, we are able to find out the various driver mutations. And ALK rearrangement is one of them. And if we talk about the stages at the diagnosis, so it's also very variable. And unfortunately, majority, almost close to 50% of the patients are diagnosed as metastatic stage. So this NSCLC is the most predominant form of the lung cancer, which accounts to 85%, and the rest 15% is small cell lung cancer. And among the non-small cell lung cancer, it is again subdivided into adenocarcinoma, squamous, large cell, and NOS. So this all we are aware of that. Coming directly to the point of ALK, we know that ALK is a receptor tyrosine kinase implicated in non-small cell cancer. It is a driver mutation, which is mainly found in the adenocarcinoma, and it accounts for around 3 to 5% of the non-small cell lung cancers, which represents close to 6,000 to 10,000 new cases in the United States, and it's almost similar in our part of the world as well. These clinical features, which are characteristics of ALK positive non-small cell lung cancer, it is usually not associated with smoking, as most patients have a no or light smoking history. Most ALK positive non-small cell lung cancers are adenocarcinoma with few reports of squamous cell pathology. And 50% of the ALK positive tumors show a solid growth pattern with more than 10% signal ring cell. So on the basis of these clinical factors and morphology, we sometimes get the idea that we are going to get some kind of ALK rearrangement. And these patients are usually younger at diagnosis. The median age is comparatively lower as compared to what we see with the other mutations. Most of the ALK positive patients have an advanced disease at the time of diagnosis, and the organ specific pattern of metastasis that differ from patient without ALK rearrangement is also different. That is, mostly 73% of the patient have pleural mets. One third of the patient might have brain mets. Then liver and pericardium are also common, and most frequent brain metastasis with NSCLC is seen with ALK as compared to the other driver mutations. So these positive small cell lung cancers, which gives you an idea, although we do not depend on this to formulate the treatment management of the patients. And the importance of the quality of life with ALK positive non-small cell cancer is also increasing as the survival rates are significantly increasing with the newer generation of drugs. So, if we talk, the median age for ALK positive non-small cell lung cancer is 51. And the median overall survival for stage 4 ALK positive metastatic non-small cell lung cancer is now 6.75 years. So, how important it is to check and find out these kind of cases, although they are 2 to 3% or 5%, but it is very, very important to diagnose them rightly, to find the right mutation and treat them rightly, so that the benefit of overall survival can be given and preserving the quality of life as well. So we know that as the patient spends more time on the therapy, there are a lot of factors which become important during the journey of the treatment of these kind of patients, especially the efficacy in the brain, because we know that most of the patient might fail in the brain, and the long-term tolerability is also very, very important. And also it is important, even we have shifted to pills in spite of chemotherapy, but to further reduce the burden of pill is also significant. If you talk about the quality of life, it is a very important attribute of the treatment. And the AlkConnect Patient Insights Network found that 88% of the patients with living with ALK positive non-small cell lung cancer have improved quality of life as a very important treatment attribute. If we talk in various factors like progression free or the treatment response, there also it is increasing. But quality of life is also catching up, and you can see that majority of the patients responded that when they are treating with the ALK directed therapy, their quality of life is much, much better. And the symptom severity has also decreased, which is statistically significant. With this high rate of incidence of ALK positive metastatic non-small cell lung cancer, we can see that brain metastasis, if they are present at diagnosis or during the treatment, they can significantly impact the patient life and the symptom burden and the quality of life. So we know 1/3 of the patients have brain metastasis at diagnosis, and up to 2/3 of the patients will develop brain metastasis during the course of the disease. So this potentially affects the behavior and the personality change, a lot of cognitive issues, including the speech problem because of the disease itself or because of the treatment. Then symptoms in terms of seizures, headaches are also very bothersome for the patients. And they add on multiple treatments for the supportive therapy, which also interacts with the primary treatment. So these patients with ALK positive metastatic non-small cell lung cancer are relatively young, and the effects of brain metastasis can be debilitating, especially those with leading busy or active lives and raising the families. So if we talk about the that is the brigatinib, what are the indications and the usage? So it is indicated as a monotherapy for treatment of adult patient with ALK positive advanced non-small cell lung cancer, not previously treated with the ALK inhibitor. It is also indicated as a monotherapy for treatment of adult patients with ALK positive advanced non-small cell cancer who have previously been treated with crizotinib. The dose is 90 milligram orally once a day for the first 7 days, and then to increase to 180 orally OD. And it can be taken with or without food, which is important because it does not have any interaction with the food. So this is how we check this, and ALK rearrangement, if it is fine, if it is discovered prior to the first line systemic therapy, then we move on to the preferred first line therapy, that is the targeted therapy and the ALK inhibitor in the first line space. If it is discovered during the first line therapy, then we can interrupt the current therapy and start the ALK directed therapy, or even we can complete 4 cycles and then change upon the ALK therapy. And upon progression, biomarker should be retested to determine the mutational status change that will inform the further treatment possibilities. So a brief overview about the drug. Brigatinib, it is indicated as a monotherapy. I've already told that as for ALK positive metastatic non-small cell lung cancer who are previously untreated, or even if they are treated then in second line post crizotinib. What is the data behind that? And we have ALTA-1 trial. So it is a phase 3 trial of brigatinib designed to demonstrate first-line clinically benefit and safety. So 275 patients with ALK positive metastatic or advanced non-small cell lung cancer, they were randomized to brigatinib versus crizotinib and crossover from crizotinib to brigatinib was permitted after the disease progression. And if we see the data in this trial, so 44% of the crizotinib patients were crossed over to brigatinib once they have progressed. This was the baseline characteristics. So it was very well matched in terms of age, sex, race, performance status, prior chemotherapy usage, and very importantly, the CNS metastasis at baseline, the histology stage, and in terms of smoking as well. So they were very well matched and balanced. And if you see the PFS probability, so you see the Kaplan-Meier curve for the PFS, it is significantly better, and at 2.5 years follow it was 9.2 months with crizotinib as compared to 30.8 months with brigatinib. So more than 3 times what we see with crizotinib. So this was a very important data, and it reduces the risk of progression by close to 60%. If you see the intracranial efficacy, because we have been focusing about that, and it demonstrates intracranial median PFS of 4 years in patients with or without brain metastasis. So it was 21.2 months with crizotinib as compared to 44.1 months with brigatinib. So it was almost double, and 56% reduction in the risk of brain metastasis with a hazard ratio of 0.44. It is also longer lasting intracranial response, which is 5.5 months with crizotinib as compared to 24 months with brigatinib. The CR rates were close to 45%, which was only 2% with crizotinib. So the median duration of the intracranial response was 27 months with brigatinib as compared to 9.2 months with crizotinib. So in almost most of the aspects, it is doing much better as compared to the crizotinib, which was the standard of care at that point of time. And patients with measurable brain metastasis at baseline also demonstrated a longer overall survival. And there also almost 57% risk in reduction. And 7 out of 10 patients with brain metastasis were still alive at 4 years. So this data is also very incredible. And if we talk about the quality of life, so that has also been demonstrated at the median time of worsening of the GHS quality of life scale was 8.3 months with crizotinib, which was 26 months with brigatinib. So here also, it is the quality of life is very well preserved in terms of physical skills, emotional, cognitive, and the social functioning skills, improvement of disease symptoms. So it is very, very important here. And if we see the clinical activity to all the 14 ALK mutations, so in cell lines also it has shown that it is active to all the ALK mutations, which is comparable with lorlatinib. Even that is also not working in one kind of mutation. And it is much better than crizotinib, then better with ceritinib and also alectinib. So this Alta-1 study, there was a retrospective chart review also among this trial, which also showed that patients who were followed from the date of last first line brigatinib dose to the end of follow-up or death. They also showed that there was a significant better responses with brigatinib, and these retrospectively also they have compared with lorlatinib and alectinib. So there also they have tried to match baseline characteristics in terms of age, female sex, and race, geographic location, then cigarette smoking, brain mets, and most of the factors which we are commonly seeing. So they are trying to balance that. And even in this real world setting, if we see, then the median time to further second line therapy or survival outcomes by second line ALK TKI was also better. So this real world evidence also gives that brigatinib is can be compared with alectinib or lorlatinib in terms of into further progression than PFS rates, and real world PFS 2, which was 51.6 months with brigatinib as compared to 30.8 months with crizotinib. So this real world evidence also gives that brigatinib is can be compared with So, if you see the use of shown by the data given by Alta 2 and rates, it was 30% post-alectinib. Median duration of response in terms of months was 6 months, and the median PFS was 3.8 months. So, it is working post-alectinib also. And so, this again, similar kind of study which was post-alectinib or ceritinib, and here it was a phase 2 study comparing whether use of brigatinib post these two ALK therapies is viable or not. So these are the baseline characteristics in this. And if you see the response rate, so majority of the patient had a significant change from the base, the target lesion. And if you see the confirmed overall response rate, so it was close to 30 months. Again, the median duration of response 4.9 months. And the intracranial efficacy was also preserved. So the key takeaway from the ALTA-2 was that it was designed to test whether the true overall response rate differs from a 20% response rate for patients who were previously treated with alectinib or ceritinib. And the overall response rate was 26% in the ITT and 29% in those who were receiving alectinib. The median duration of prior alectinib treatment was shorter in the ELTA-2, which was 11.6 months compared to the previous study. And it also demonstrated clinically meaningful activity with the next generation ALK-TK in the number of clinical trials. And the safety profile was also consistent with what we have seen with the other previous study of the brigatinib. And the most common side effects, which were more than 10%, was included the CPK increase, diarrhea, nausea, uh, increase in serum lipase, and liver dysfunction in terms of AST and ALT increase was seen along with hypertension. So these side effects needs to be monitored. If we talk about the safety profile overall, so ILD was seen in 6% of the patient. Grade 3 or more than grade 3 ILD or pneumonitis was seen in 3% of the patient, which was very less than comparable to alectinib. The recommended dose, what I previously told, was 90 milligram in the initial 7 days, then increased to 180 milligram. And it is given irrespective of the food, it is to be swallowed. And to avoid grapefruits or which is in general for most of the chemotherapy and targeted therapies. So with this, would like to summarize that brigatinib in ALTA-1 trial has a very powerful systemic efficacy and durable intracranial efficacy, which is demonstrated with median PFS of 44 months as compared to 21 months with crizotinib in patients who have baseline brain mets. It also have a superior intracranial efficacy, and the risk of progression or death was reduced by 75% as compared to crizotinib. And it also demonstrated good safety profile with few side effects like pneumonia, ILD, fever, and pulmonary embolism close to 2%, along with few basic parameters to be monitored. So that's all from my end. Thank you for your patience listening. Happy to take any questions or any comments.
Do we have any questions?
Thank you, Dr. Ankit, for this wonderful presentation. What is your personal experience in your practice with brigatinib?
So personally, I have not used brigatinib because it's recently launched. I had a few queries regarding the
Especially
response
for
rate
us.
as compared. Sorry,
So
you were saying something.
data is very promising. So I just wanted to know your practical insight. So what is your practical?
What I have learned from reading the trials that yes, it's a very good drug. The efficacy and the intracranial efficacy is also very, very good. And it is comparable to alectinib and somewhat to lorlatinib. So any patient, especially who is not fitting into or because of the toxicity concerns of the lorlatinib, especially the cognitive or the dyslipidemia. So if we are not able to give lorlatinib, then definitely near equivalent drug which we can give in those kind of settings.
Yes, thank you, Dr. Ankit.
Thank you, sir.
Thank you. So let's begin with the next talk, which is the last one for this day. So I would like to invite Dr. Vipul Nautiyal, who is Professor and Head Radiation Oncology, HIMS Dehradun, and he will speak on SBRT in lung cancer.
Good evening, everyone. Am I audible? Hello.
Yes, sir, you are audible.
So, good evening, everyone. First, I would like to thank Dr. Chandra and Dr. Amit Serawal for inviting me as a speaker. So, my today's is it my PPTs or visible? No.
Not yet, sir.
Okay, 1 minute.
Yes, sir, it's visible. Kindly make it full screen.
Okay. So my today's talk is on SBRT in lung cancer. What are the evolving technique? How will you integrate the systemic treatment? So first, the non-small cell lung cancer. 1 minute, is it? Yeah. So first, the non-small cell lung cancer is the leading cause of cancer-related death in the US, as approximately 20% of the patients are diagnosed in an early stage. Although in India, it's very early stage cancers are very limited. We are finding not less than 10% of the patients. Only the screening method can detect the early, or incidental finding can find some early cancers. So the gold standard for the treatment for early stage is surgical lobectomy plus minus mediastinal lymph node dissection. And now the another option is SABR, stereotactic body radiation, which is safe, effective, efficient standard treatment for early stage non-small cell lung cancer, especially for stage 1, and is considered for the standard treatment mainly in the patients who are medically inoperable or functionally inoperable, or those patients who are not willing to go for surgery. So first, the question is, what does the SBRT do? SBRT basically, we are giving the high doses radiation to the tumor. So that basically affect the different kind of effect. First, it's killing the tumor cells, as well as it also generating the immunogenic cell death abscopal effect, which activate the CD8 cells, which causes, which is killing the surrounding tumor cells, and also create the microenvironment modulation. This is the picture showing how this radiations when act on the tumor cells, and which increases the CD8 cells and it recognizes the multiple tumors and killing the remaining tumor cells. And there are the various other methodology by which these body immune system which activates against the tumor. So the key questions are
Sorry to interrupt, but your slides are not moving. Are you moving the slides? I'm not sure.
Is it moving?
Not yet.
No.
No.
I don't know because
Yeah, now it's moving.
so I have to now is it visible to everyone?
It's visible, sir, and it's moving also.
Yes. So the key questions of my today's presentation: when is SBRT a reasonable consideration for stage 1, and should we ever consider for adjuvant treatment, systemic treatment for these patients? So first thing, we have to revise our staging. The T1, T2 tumor, where the tumor size should be less than 5 centimeter. In the T1 is less than 3 centimeter, and T2 is 3 to 5 centimeter. And in the T1, there is no involvement of the main bronchus. In the T2, where the main bronchus involved, but without the carina, that should be 2 centimeter away from the carina. So this is the picture is showing how the localized area of the tumor is getting high dose of the radiations. Because SBRT is basically highly precise form of radiation which delivers the high dose radiation to the tumor, and is with the extreme accuracy and minimal damage to the surrounding tissue. Because we know that the lung is very movable structure, so we have to take care of the movement of the lung by doing the 4D CT. So we have to take the different CT scan in the different phases, inspiration and expiration phases, and then we have to localize the tumors by which we can reduce our margin around the tumor. So delivery is via special design coordinator system, where we can localize the tumor and treat with the limited and precise fields. So advantage of this SBRT, we can give the treatment within a short period of the time, and it reduces the side effects, and it increases the high tumor control. And but the availability of SBRT nowadays increased rapidly over the past decades. So these are the various scientific literature which have shown this definitive SBRT is the recommended treatment in those patients who are having early diseases, and they have found the local control in 3 to 5 years almost 85 to 95%. So these are the various selected study which have shown the local control is almost above the 80 to 90%. But the overall survival is still 70 to 80% in all these studies. In spite of good local control, still patients are failed distantly. So there are systemic failures in almost in 30% of the patient. So these are the various study which have shown the local control almost 85 to 90% in 3 to 5 years. But the survival is varying between the 50 to 95, is approximately 70%. So these are the various RTOG trial which have initially the phase 1, phase 2 trial, which have shown that tumor who are less than 5 centimeter, they are having they were treated with the SBRT, and they found the local control was above the 80 to 90%. So these are the various challenges and limitations addressed in the last 2 decades. One is the treatment-related toxicity. Is basically when you are treating with a high dose of the radiation, the volume of the radiation should be minimal. Otherwise, patient will develop the late toxicity like fibrosis, pneumonitis, esophagitis, esophagus. That's why the central or ultracentral tumor should not be treated with very high doses because of the late toxicity of esophagitis, as well as the chest wall toxicity if the chest wall or pleura is involved. So patient selection criteria is very important, in which you can challenge. There are the various challenges. You have to find the optimal identifying very good candidate which can go for SBRT. So adjuvant treatment is totally depends on the tumor characteristics, performance status, and other comorbidities apart from the performance status. So how will you assess the advanced treatment modalities? Is limited access because this advanced treatment is not easily available, and it's time taking. And because if you want to treat any patient by the SBRT, you have to take the 4D CT scan, and for which patient has to lie down almost half an hour to 1 hour, and patient has to be trained accordingly because the CT scan has to be taken in different phases of the respiratory cycle. So patient should be trained initially. So it's a time-taking process. Although treatment we can finish in the 5 to 8 fractions, but the planning and treatment planning and everything takes time. So these are the various type of lesion where you can easily give the stereotect SABR. First is the peripheral lesions where tumor should be 2 centimeter away from the central area like trachea or primary bronchi. The central lesion you can treat, but still it should be far away from the bronchial tree. It should not awaiting the mediastinal pleura. Ultracentral lesion you can treat, but you cannot deliver the high doses because it leads to the toxicity. So the consideration of stage 1 non-small cell lung cancer, most of the established SBRT criteria where the tumor site should be less than 5 centimeter, and ideally it should be located peripherally. So peripheral located, the minimal mediastinal lymph node involvement, ideally patient should not have the mediastinal, otherwise it's go to the stage 3. So that should not be treated with the SBRT. And there should be absence of extrathoracic metastasis, and the tumors may or may not be or cautiously treated with the number of fraction we can increase on those tumors where the central or ultracentral locations, and the patients who are having the multiple synchronous lesion or if chest wall invasion. As we know, the late toxicity of SBRT is more if we are treating in the central lesions because of esophagitis or chest wall toxicity. So there are the literature which have treated the patient with the central and ultracentral lesion, but the number of fraction they have increased. So there are some retrospective prospective studies which they treated the patient with the 60 grain in 12 fraction. Number of fraction they have increased so that the toxicity, late toxicity can be decreased, mainly in the lesion which are central or ultracentral lesions. So there are the various studies which have shown the stereotactic radiation in the mediastinal as well as the hilar areas. But as I said, the number of fraction has to be increased because of the toxicity. So SBRT nowadays recommended only in stage 1, ideally the less than 5 centimeters of the tumor, or those patients who are medically inoperable, they can't go for surgery, elderly patients, and the patients who refuse for the surgery, oligometastatic patients where the metastatic disease is only 2 to 3 sites, and the patient selection is also very important, where you have to monitor his pulmonary function test. DLCO should be less than 40%. Patient cardiac, cerebral, these are the related contraindication in which you have to choose the patient wisely. So these are the various guideline, NCCN guideline, which is showing the patients who are medically inoperable or high risk surgery, they can be treated with the stereotactic body radiation. So this is the another stage 1B, in which they have treated the non-negative patient can be preferably treated with the stereotactic radiation. So the now question is because as we know that the local control is still very high, almost equivalent to the surgery, but still the patients fail distantly. So the local control in early stage after SBRT is high, as we discussed, but the adjuvant treatment is aimed to eradicate the micrometastatic disease, and that will lead to the improved long-term outcome. Although there is no randomized prospective studies which have examined the addition of chemotherapy before or after stereotactic body radiation, because most of the patients are stage 1. So still it is lacking, but there are the various studies which have presented the phase 1, phase 2 trial, which they have shown there is a benefit. So now we can extrapolate this from the surgical change. Like this is the Pignon et al. 2008, in which they have treated the patient after surgery with their adjuvant chemotherapy. So they analyzed almost the 5 randomized trial and demonstrated the almost 5% benefit over the 5L with giving the adjuvant chemotherapy in early stage of the lung cancer. This is another trial, GBR10 trial, which have also shown the significant improvement in the overall survival in 5 years after. So this is the Anita trial, CalGB trial. They all have shown there is a benefit in the patients who are having high risk of failure. So these patients can be treated with the adjuvant systemic therapy, and 5% approximately in a 5 year the benefit in overall survival. So now you can see the indication for adjuvant systemic therapy in early stage patients, in which the tumor size is large, more than 4 centimeter, LVSI positive, visceral prelar positive, any close and positive surgical margins. These patients should be treated with the adjuvant systemic treatment. And there are the histological type. If the patient is having some unfavorable higher risk of recurrence, in those patients should be treated with the adjuvant system. So biomarker studies also there, in which EGFR, ALK inhibitors should be considered after the surgery. So, but the EGFR mutated patient, as we all know, the stage 3 after the this LAURA trial has shown the benefit of giving the maintenance of osimertinib, but the early stages still there is no clear-cut guidelines to giving the osimertinib. So this is the as we discussed in the NCCN, which have shown that the preferably SABR in early stage of non-small cell lung cancer, where the surgery medically inoperable patients. So adjuvant systemic therapy in patients with the early stage non-small cell lung cancer were treated with the SABR. So this is the one of the trial which have shown that their patient was treated with the adjuvant chemo, and the tumors was greater than 4 centimeter. In those tumors, they have treated with the adjuvant. The patients with a small tumor, no clinical evidence of lymph node does not appear to be survival benefit by adding the adjuvant treatment. So this is the another trial which have shown the adjuvant chemotherapy following the SBRT for early stage non-small cell lung cancer. Still, they have shown there is a benefit in the overall survival. Only in the patients who were having the large tumor more than 4 centimeter, they were getting the benefit after of chemotherapy after SBRT. So there is some trial which is also assess the benefit of SBRT in tumor which are more than 5 centimeter, and with the chemotherapy is associated with improved OS. But the challenge to give the large tumor with the SBRT high doses, it's very difficult to treat, and because the volume of the radiation will be more, and the patient will have the most toxicity. So these are the dose individualized stereotactic radiation, in which, as I said, the BD biologically effective dose should be the 100, more than 100 K. This is the basic rationale to give the SBRT, and the number of fraction has to be. We can can be varied depending on the patient's location of the tumor, size of the tumor, and other comorbidities. So there are some phase 2 studies which have shown the giving the immunotherapy in those patients with the SABR. And the initially phase 1, phase 2 trial, they have shown slight benefit in overall event-free survival. Still, there is no recommendation, if there is no guideline, no phase 3 data or randomized trial which have shown the benefit, but still there are many trials which are coming. They are combining the SABR with the immunotherapy. So in selected the consideration of combining the SBRT and adjuvant systemic treatment, so selected cases, combined approach SBRT followed by adjuvant systemic may be warranted, especially in the patient who are having the high risk of failure or molecular alteration which can predict the systemic failure. Or there are various retrospective studies which have shown there is a benefit of giving the adjuvant treatment in the patients who are having high risk of failure. The tumor size is more than 4 centimeter. So all the treatment should be given after the multidisciplinary discussion. The treatment decision of combining SBRT and systemic treatment should be made in a multidisciplinary because there is no level 1 evidence to give the systemic treatment in those patients with the early stage. Timing and sequencing of SBRT and adjuvant systemic treatment should be carefully evaluated, especially in patients as well as tumor toxicity, treatment toxicity, patient's comorbidity, performance status. These are all the things we have to see the patient before enrolling any patient for the SBRT or any kind of systemic treatment. So the clinical selection, early stage non-small cell patient with a central tumor, high risk feature may benefit by giving SBRT. Oligometastatic patients you can treat with the SBRT. If 4 to 5 lesions you can treat with the SBRT. And contraindication, if you are combining any immunotherapy, so autoimmune other LD or patient is already compromising his lung functions, in those patients this treatment should be avoided. There are the various trials are undergoing which in future maybe that will come which combines the stereotactic radiation with the immunotherapy. So conclusion is basically the SBRT is effective treatment option for stage 1 non-small cell lung cancer and the patients who are medically inoperable or patients who are not willing for surgery. Adjuvant systemic treatment is a crucial role basically in those patients who are in a high risk of failure. Basically, the tumor size is more than 4 centimeter. Still, there are very landmarks supporting its efficacy. So integration of any SBRT adjuvant treatment into multidisciplinary treatment approaches for non-small cell can lead to improved outcome, and it leads to the personalized care studies. So thank you. Although SBRT has also role in a radiation for locally recurrent diseases and as well as in the oligometastatic diseases. Thank you. Thanks. Hello.
Thank you, Dr. Vipul. Thank you for the wonderful talk. So, do we have any questions?
Thank you, sir. Thank you for wonderful talk. How frequently you are offering SBRT in lung cancer patients?
Actually, it's very difficult. Although in metastatic, oligometastatic, we are treating the patient, but not in the stage 1. Stage 1, it's very difficult to find because although 1 or 2 patients we have found, but the making the diagnosis of those patients was very difficult, was challenging to do the FNAC biopsy from the central lobe of the tumor.
But oligometastatic disease, metastatic disease,
we are treating with the SBRT.
Okay, thank you, sir, for this.
Okay, so we have come towards the end of this meeting. I would like to invite Dr. Amit Sehrawat, sir, to give the closing remarks for the day.
Thank you. First and foremost, I would like to thank our convener, Dr. Chandra Goda, for taking initiative and conducting this meeting on such a short notice. Then all the speakers, faculty, Dr. Sajan Rajpurohit, Dr. Abhishek, Dr. Vipul, Dr. Ankit, all the panelists in the panel discussion. Thank you everyone for contributing wonderfully to this academic event. And the event manager team, Yashika et al. last but not the least, sponsors, especially Tyagi ji from AstraZeneca. Thank you everyone for making this event successful. So we are going to stop here. Thank you, Yashika.
Thank you, Amit sir. Thank you, everyone. So everyone can log off the meeting. Support team, please close the meeting.
Okay, ma'am.
ठीक है, good night.